As Barry mentioned, I'm going to be talking about my research proposal, and this is for a feasibility study, looking at trying to identify multiple sclerosis. Sorry, I'm a little bit short in the IDI, with an aim to then have a larger project looking at identifying other complex illnesses, learning from the feasibility study with multiple sclerosis. So I'll talk about the wider context a bit first, and then I'll go into a bit more specifics about the plan for multiple sclerosis. So first of all, I'll go over how to define complex chronic illnesses. So these are illnesses that are not well understood, are difficult to diagnose and treat, cause substantial morbidity, and have fluctuating severity over time. These illnesses tend to disproportionately affect women and girls, and they typically receive little research funding or policy attention. So it's easier to understand what sort of conditions I'm talking about with some examples. So if you'll please bear with me, I have a very quick activity for us all. Please raise your hand if you've heard of each illness as I read them out, or if you're too shy, just say it in your head, please. So who has heard of multiple sclerosis? Yep, that's what I expected. Pretty much, I think that was everyone, or nearly everyone. And endometriosis? Yep. But what about myalgic encephalomyelitis? Yeah, that's a bit more fewer. What about chronic fatigue syndrome? Okay, a few more. Well, who here knew that myalgic encephalomyelitis and chronic fatigue syndrome are the same condition? And fibromyalgia? Yeah, a few more there. Migraine, yeah. Lupus, yeah. Ehlers-Danlos syndrome? Ah, more than I would have expected. Yeah. POTS, postural orthostatic tachycardia syndrome, only a few there. And mast cell activation syndrome. Oh, that's way more than I expected. And then long COVID. Yeah, pretty much everyone. So a thing to note here is, many of you may be aware, a lot of the conditions that we're seeing in long COVID have been known about for a long time, with the exception of mast cell activation syndrome, which is pretty new. Yeah. So to give you a sense of the scale of this, I've got some very, very rough prevalence data. So just a caveat, this is based on what I could find of these conditions which don't get a lot of research funding or attention. So some of them are for other countries, and some of them are quite old. And in particular, the long COVID and the ME/CFS estimates are likely to be quite an underestimate. As anyone in the ME/CFS community will know, the prevalence of ME has likely increased dramatically in the last few years. And that's an estimate from before COVID. So even with these funding estimates, you can see that really substantial numbers of people are affected by these conditions in Aotearoa, New Zealand. However, many of these conditions are not really on the radar, and they do not really have clear pathways for health or social support. Part of the difficulty accessing care for many of these conditions is due to underfunding of biomedical research. So I just wanted to highlight a study by Mirren, where they looked at NIH funding in the US by the proportion of the condition who were male or female. To quote this paper, they found that in nearly 3/4 of the cases where a disease afflicts primarily one gender, the funding pattern favours males, and that either the disease affects more women and is underfunded with respect to burden, or the disease affects more men and is overfunded. So this is especially obvious for ME/CFS and migraine, which only received about 7% of the funding you would expect given the burden of disease caused by these conditions. So this has substantial impacts on people with these conditions, their families, and our wider society. However, this is also likely to disproportionately affect people from ethnic minorities and people from low socioeconomic backgrounds who already face additional barriers to accessing healthcare. So this was highlighted in the report by Jeffries and colleagues, who conducted a number of interviews with people who caught COVID-19 before December 2021. And one of the findings from the study was that over half of study participants with long COVID did not agree that they had received adequate health, which was 56% for tangata whenua and 53% for tangata tiriti, or social care, 47% for tangata whenua and 33% for tangata tiriti, for ongoing COVID-19 symptoms or long COVID. Additionally, tangata whenua were more likely to report not seeing a GP for long COVID symptoms when needed due to costs than tangata tiriti. As another example, Jason and colleagues conducted research that involved randomly contacting families in the Chicago area and screening children aged 5 to 17 for ME/CFS. While ME/CFS is more commonly diagnosed among Europeans, these studies showed that the prevalence is actually higher among ethnic minorities in the US, mirroring findings for adults in a similar study conducted by the same researchers. So on to the motivation of the study. So the motivation is to develop ways to identify these conditions in the IDI to facilitate wide-ranging research. For example, a woman with endometriosis less likely to be in full-time employment than their peers. Are there ethnic inequities in access to migraine medications? Are people with ME/CFS less likely to receive support services than people with other disabling conditions? So to facilitate further research, this project was produced code to identify these conditions. Additionally, as any cohorts of people with conditions on the IDI will only represent a subset of the true population with the condition, part of this project will involve trying to understand these biases and provide guidance on the implications of these biases for research on these illnesses using the IDI. So the project will start with a feasibility study, which will see whether it is feasible to use the IDI to test for treatment inequities in multiple sclerosis by asking the question, are there differences in prescriptions of disease-modifying treatments for patients with multiple sclerosis by ethnic group and also socioeconomic position? So multiple sclerosis is a chronic demyelinating inflammatory disease of the central nervous system, which can cause a range of neurological symptoms, profound fatigue, cognitive impairment, and substantial disability. There are 8 funded disease-modifying treatments in Aotearoa, New Zealand, which can slow the progression of the disease. However, the criteria for these treatments is relatively strict, although they have changed somewhat over time. And to my knowledge, there hasn't been any previous analyses of whether these treatments are being prescribed equitably in Aotearoa, New Zealand, although international research has found disparities by area deprivation. So the first step of the feasibility study will involve constructing cohorts of people with multiple sclerosis in the IDI using data on hospitalizations, disability service use, pharmaceutical dispensing, and potentially outpatient and emergency department visit data. Notably, people who are only identified from pharmaceutical data will be excluded from step 2, which will be to test for differences in prescriptions for disease-modifying treatments by ethnic group and socioeconomic position using a series of binary and multinomial logistic regression models. The ethnic groups that will be examined are Maori, Pacific, Asian, and European, with people counted in as many ethnic groups as they identify with. So one of the advantages of using the IDI is that it is possible to combine information from many different tables. So for instance, several different aspects of socioeconomic position will be examined, including education, income, area deprivation, and occupation using census, Ministry of Education tables, inland revenue tax records, and the address table to link to NZ debt scores. So this will help us to better understand the drivers of any potential inequities identified. Models will control for age, gender, disability, and relevant comorbidities. The rationale for controlling for disability is that the expanded disability status score, which mostly measures mobility, has been an important part of the eligibility criteria for these drugs. However, there is no direct measure of this in the IDI. Instead, a proxy measure will be constructed using the disability information at census, which uses the Washington Group short set and the disability support services data. So here we have a table showing the disease-modifying treatments available, organised by the date they became available in New Zealand. As you can see, only low efficacy disease-modifying treatments were available initially, with a shift to higher more efficacious disease-modifying treatments with higher efficacy later on. Because of this and changes in the eligibility criteria over time, it will be necessary to split the cohort into people identified as having been diagnosed before November 2014 and those diagnosed between November 2014 and March 2021. For the first cohort, we'll test whether the odds being prescribed low efficacy DMTs or no DMTs differed between 2006 and November 2014, or as only low efficacy DMTs were available at the time. For this cohort, we'll also test for differences in the odds across different levels of efficacy. For the second cohort, we'll just compare the odds of being prescribed a high efficacy DMT versus any other. So there are a few caveats to outline. The first is that we will not be able to know when people were actually diagnosed with MS. We can only know when they first appear in our data. The second is that these analyses may need to be modified due to small counts, depending on how many people we can identify. And the third is we cannot know the particular reasons that a person was prescribed a particular treatment. Importantly, high efficacy disease-modifying treatments generally have a worse profile to earlier disease-modifying treatments, so may be less appropriate for some patients. And this could vary systematically by socioeconomic position or ethnicity. So a big part of the feasibility study will involve comparing the characteristics of cohorts identified in the IDI with other published material, considering things like the distribution of gender, ethnicity, age, and geography. And this is one of the advantages of looking at multiple sclerosis for the feasibility study, is there is actually quite a lot of work looking at the prevalence of multiple sclerosis. Yeah, and so as part of this, we'll compare against those, the findings of those studies, and also back to the usually resident population. Step 4 will identify the key advantages and limitations of using the IDI to identify multiple sclerosis, and by extension, other complex illnesses. And as part of step 4, we will reach out to potential collaborators and advisors on other illnesses to study. So there are some substantial challenges with identifying complex illnesses in the IDI. In particular, there is no diagnostic primary care data in the IDI currently, and this is where many people with complex illnesses access care. In addition, there is likely to be a lot of misdiagnosis, and in particular, underdiagnosis of many of these conditions, and this is likely to be differential by ethnicity and socioeconomic position. And some conditions do not seem to have suitable ICD codes, or only very recently given ICD codes, and many illnesses don't have good prevalence information available to facilitate an understanding of the biases introduced by using administrative data. And lastly, for MS, as I noted previously, only a small number of cases likely to be identified, and the estimated prevalence of MS is lower among Maori and Pacific peoples, which increases the potential for missing treatment differences that do exist due to lack of statistical power. So in conclusion, the current research will use MS as a test case to better understand the strengths and limitations of using the IDI to study complex chronic illnesses, while also testing for treatment inequities. Identifying treatment inequities is the first step in changing practices and policies to reduce inequities. So this research will hopefully lead into a larger project with the aim of creating methods to identify a range of complex chronic illnesses in the IDI, so these can be used by other researchers. The hope is that this overall project will highlight and improve understanding of the barriers that people with chronic complex illnesses face in trying to access healthcare and social support. These barriers are likely to be at least partly due to gender bias in medicine, and these barriers are likely to be amplified for Maori and Pacific people and people from low socioeconomic backgrounds who also have to navigate systems that weren't necessarily built for them in other ways. So I'd like to acknowledge the Health Research Council for funding this feasibility study. I'd also like to acknowledge all of the collaborators on the study, as well as StacksNZ for creating and maintaining the IDI and supporting all of us IDI researchers. And thank you to all of you for listening. Does anyone have any questions or comments? Annie first?
This is more a question about what your instinct is, because I've had a very similar question asked of me recently. Do you feel like these complex conditions, there needs to be this like indicator event that allows us to actually pick them up as part of the whole, like for MS, it's the pharmaceutical prescription that they receive. For endometriosis, maybe it's the the laparoscopy that they receive. Like, is that what is the necessary component for us to be able to do this kind of work? Or do you think eventually, somewhere down the line, we might be able to come up with profiles for diseases that don't have those specific, things done to them,
I mean, it's so tricky, right? Like a big part of it is just of the project plan is just trying to understand who you can get from those things. But some things like ME, it seems like we need a registry or something. And the lack of primary care data is such a problem. I'm not sure if I answered that question, but I think it'll differ depending on the condition.
I think I'm probably asking the same question, but I'm not sure. So is there any way, I think this is, first of all, it's really good research because it's going to help the others who are going to look at these, chronic conditions and where the prevalence is less in the population. Because we also had a bit of issues when we're looking at one of the chronic conditions like type 1 diabetes, and then trying to find an algorithm to find out the number of cases. For this one, do you think there's any way you will be able to validate the IDI data against some sort of registers?
Only for MS, I think. I'm not aware. I mean, I could be unaware of other ones, but I'm not. I mean, some of the smaller ones in the more neuroimmune side of things, there's just so little out there about them.
And even in hospitalization data, there may not always be a diagnosis with them, right?
Yeah, and you're going to be picking up on secondary diagnoses to get some of the conditions as well. And you're only ever going to be getting the tip of the iceberg, IDI. Eric?
Yeah, in your discussions with your collaborators there, do any of them have a connection to primary care data? That's what I was thinking. Because it would be really, I mean, your working assumption, which I have no doubt is true, is that you pick up a lot more of these cases in primary care. There's no nationwide primary care data, but there are people doing little bits and pieces, Rob Jackson being one, for instance. I just wonder if a step on from this is to take what you've got and then look what you could get if you had primary care data.
Yeah, I think that's a good point. I'll follow up with you.
They didn't mention on the way through, hey, it would be cool to look at primary care data, but I've got a connection to X or something like that. No one said that.
It hasn't really come up yet, no.